Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, honorable professors, respected consultant, radiologists, all dear residents, and all participants present today. I am Robiatul Adoya. It is our great pleasure to welcome you to today's resident lecture with Professor Dr. Mahesh Prakash, and the topic today is the role of MRI in bone and soft tissue tumor. On this special resident lecture, allow me to respectfully acknowledge our honorable head of the Department of Radiology, Dr. Sutomo General Hospital, Professor Dr. Rosy Setiawati, specialist in radiology, subspecialist in musculoskeletal radiology consultant. Our respected speaker, Professor Dr. Mahesh Prakash, and all dear participants present today. Hello, Professor Mahesh. Welcome to Surabaya, Prof.
Yeah, thank you. Thank you very
Hello.
much. Thank you very much.
Okay, thank you very much, Prof. Mahesh. We are truly happy to be with us today. And this lecture will be moderated by our respected teacher, Professor Dr. Rosy Setiawati. But before we begin, please allow me to briefly introduce today's moderator curriculum vitae. Professor Rosy Setiawati is a consultant radiologist with subspecialty in musculoskeletal imaging. She completed her medical degree and radiology residency at Airlangga University and Dr. Sutomo General Hospital, followed by fellowship trainings in Singapore and Italy. She also holds certification as a clinical densitometrist from the International Society for Clinical Densitometry. Currently, Prof. Rosy serves as the head of the Department of Radiology at RSUD Dr. Sutomo and the chairman of the Board of Collegium Radiology of Indonesia. She is also actively involved in several national and international professional societies, including the Asian Musculoskeletal Society and the International Society for Clinical Densitometry. Prof. Rosy has published extensively in both national and international journals, contributed to academic books, and has been an invited speaker in numerous scientific meetings worldwide. With such an outstanding academic and professional background, it is our honor to have Prof. Rosy moderating today's lecture. Now, we will kindly invite Prof. Rosy Setiawati as a moderator.
Okay,
Good
hello, Dr.
afternoon,
Robi.
Prof.
How are you? How are you, Dr. Robi?
Oh,
Good.
I'm fine, Prof. Thank you.
Okay, so I can start the session right now, Dr. Robi, or
Yes, Prof.
yes. Okay, thank you, Dr. Robi,
Take the
for
floor.
introducing me. And first of all, I would like to say hi to everyone. Good afternoon, everyone. And thank you for joining us for this webinar, especially for the resident lecture organized for the radiology residents and collaborated with the uh, Indonesian Radiology of Collegium. And I'm Dr. Rosy Setiawati, and I will be your moderator for these sessions. And I'm very glad to introduce my the distinguished guest speaker, my old friends. Yeah, that is Professor Mahesh Prakash. How are you, Professor Mahesh Prakash? We already met
Thank,
few minutes ago, yeah. And then he
yes, thank you.
separately joined the webinar right now. Yeah, I will introduce Professor Dr. Mahesh Prakash, MD, FIACM, FIMS, and FICR as our distinguished guest speaker. And he is a professor of the Department of Radiodiagnosis, Postgraduate Institute of Medical Education and Research in Chandigarh, India, with more than 20 years of teaching experience. Wow, so long, yeah. And he currently leads some MSK Radiology Fellowship program in his department. So I know that he has been received as the various national and international awards because we are working together at EMS, and maybe he also involving in very international society of us or musculoskeletal as well. And he already has several or a lot of journal that has been published by Professor Mais Prakas. And thank you so much, Prof. Mahesh, for your willingness to accept my invitation because it's very sudden, yeah, to invite you. But fortunately that you accept my offering, and finally we can meet him right now. And today, so we hope that we this webinar will open the opportunity to deepen our understand and our skill and radiology, especially in MSK radiology in bone tumor and soft tissue tumor through the expertise of our distinguished guest speaker. And this webinar aims to support your learning journey as resident. And Prof. Mahesh, I have invited, yeah, more or less about the 14 institution in Indonesia. I don't know how many because my webinar or Zoom is limited in capacity, but they also can join the live streaming in YouTube. Yeah, so this is really honor for us to have you right now. Yeah, in Indonesia and in Surabaya as well. And for all the participants, um, before we beginning, so some few notes that will be informed to you that please keep your microphones muted during the presentations to avoid the noise. And if you have questions, kindly type them in the chat box, or we will address them in Q&A session later after Prof. Mahesh finished the presentation. And I appreciate your active participations and encourage you to take a full advantage of these sessions by engaging in discussing and asking questions. And without further ado, let us warmly welcome our speaker, Professor Mahesh, to share the valuable knowledge on topic of MRI in bone and soft tissue tumor. Please, Professor Mahesh, the time is yours. Thank you so
Yes.
much.
Thank you, Professor Rosy. So it's a nice words from you, and always like very important. And I always eager to look forward to meet the Indonesian people here and like to have the words with the all the Indonesian the guys. And I know that the Indonesian students are very bright. All the residents, the all the consultant, everybody are so nice and they are ready to. Important thing is to ready to learn. So that is the important the part which I have seen very closely. So thank you very much again for the kind introduction and saying very good for me as well as my work. So thank you very much. So let's start this the webinar. So I'll share the my presentation here and just let me know if it's visible to you. Uh, it's okay. Can you see
Still
my the
processing on
screen?
sharing. Yeah, still processing on share.
Okay, okay.
Okay,
So
right
let
now we can see. Okay,
okay. Let me know if it's so my voice is okay and my present the screen is okay.
yeah, I
That's
can
okay?
hear you so
Okay,
clearly.
thank you very much. Thank
Mahesh,
you.
thank you.
So, okay, so again, so let's see the what we try to discuss in this webinar is that we'll see that how the MRI can be useful in cases of bone and soft tissue tumor. So, in next 30 or 35 minutes, we'll see by example how the MRI can be very, very useful and helpful, not only in the diagnosis, but in the management of the bone and soft tissue tumor. So, okay, let's see. Yes. So I have nothing to disclose. So we all know that the if you want to evaluate the bone and soft tissue tumor, we may require more than one imaging modality. Obviously, the radiograph, like since many years, we have seen that the radiograph is the cornerstone. And when we were the resident then, and always this kind of teaching was always there, that the radiograph, you should not miss the radiograph. So again, this point goes to all the resident. The radiograph is very important, particularly the bone tumors, whether it is the benign bone tumors, less aggressive tumor, or malignant bone tumor. You should always look whenever there is a patient of the bone tumor comes to you because it detect the lesion whether because even nowadays even people look back also like after doing the MRI they try to see whether the lesion looks like aggressive or non-aggressive on the radiograph. So the radiograph remain still in this era of MRI or advanced technique. Radiograph still are valuable and always look for these the radiograph whenever available. The CT is particularly useful in cases, complex anatomy cases like the pelvic bone or the hip region, shoulder region, where there is a overlap of the bones. So the CT is quite useful in those situations, and it provides the bony anatomy actually. So bone, like if you want to see that many time, a little bit of bony erosions are seen on radiograph on or even on the MRI. And so sometimes even the surgeons ask about the CT scan also. So CT scan is particularly useful in those situations where we need to know about the fine detail of the bony outline. Ultrasound obviously is very useful in cases of soft tissue tumor, because many times the patient presented with the soft tissue swelling, and even the clinician don't know about whether this lesion is a non-tumorous conditions or the tumorous conditions. If the tumor is there, what kind of tumor is there? So ultrasound is very good for the soft tissue tumor. So learning point here, two important learning point for the resident. For bone tumor, radiograph is very, very important. For soft tissue tumor, ultrasound is very, very good. MRI has a role, and we will discuss this role of MRI in subsequent slide. So these are the modalities available nowadays. We know about it that radiography is available. We know we have ultrasound. We know the CT scan. MRI has a role. Even people are using scan as well as the PET CT scan in bone tumor also. But our topic today remain the MRI. So we will discuss in detail how the MRI can help. Obviously, the ultrasound and CT, as I said, it's are helpful, but we are not explaining today because of the limited time. So we'll discuss MRI today. We all know that the MRI is a profound effect because we know that it provides excellent soft tissue contrast and for the soft tissue lesion, and then also detect the bony the pathology, particularly in the medullary region. So very, very useful. So what are the advantages of MRI? We all know, most of the people who know about it, that in comparison to CT scan, MRI does not have a ionizing radiation, multi-capability, planar capability, excellent soft tissue contrast, as I said. The important thing of MRI that it detects the extent of lesion. What is the extent of that particular lesion? If there a lesion is limited to the bone or there is a soft tissue extension. What is happening to the marrow? As is the marrow involved, or only the cortex part of the bone is involved, and the neurovascular bundle. So these all four components: extent, soft tissue extension, marrow infiltration, and neurovascular bundle. These all four component is very, very important for surgeon's point of view also, because they manage accordingly whether neurovascular bundle are involved, how much soft tissue contrast is there, or the lesion is only limited to the bone. Not only this one, it MRI can also characterize the soft tissue lesion, like whether the lesion is a fat containing lesion or it is a fibrous lesion, whether the lesion looks like the benign lesion or a malignant lesion. So MRI can also help on those situations. So on both the bone tumor as well as in the soft tissue tumor, MRI is useful. So what is the role? And we will discuss
Sorry,
in
Prof.
detail.
Mahesh. Sorry,
Yes.
Prof. Mahesh. I think your slide is incomplete because maybe some problem. Would you please,
No,
if
you.
you can stop share first and then you can rejoin.
Sure, sure, sure,
Yeah, you
sure.
can reshare. Sorry.
Yeah, okay.
I hope that it will better.
I'll check
You just
now.
stop share first
Can
and then stop share and then reshare again.
Yeah, I'll just check it.
Sorry to interrupt
No, it's
you.
okay. I think because until if you are not able to see, then what is the use? So
Okay.
that is the more important.
Maybe
So
because
let
it's
me let,
close
yeah,
this
let me
yeah.
check, and you let me know that whether this is uh, coming. And I'm just full screening it, and then what about this now? Or again, it's not
Yeah.
complete. Just
Oh
let me know,
yeah, yeah.
okay?
No problem. That's okay. I
I'm
think
just
yeah.
going back and just see that now it's coming fully.
Yeah,
See, I'm
we
just going,
still
it's
can.
okay
Yeah,
now?
that's okay. I think maybe there is a problem from the Zoom. I think, yeah, go on.
Okay, okay.
Go on.
Right now is okay? So
Yeah,
should I
okay.
continue now?
We can still just a part, just most of your slot we can see, but it's just a small part is covered by some block
Okay.
color. Yeah,
It's
that's
okay,
okay.
then should I
That's okay.
continue
I
now?
can I can still see right now.
Okay,
Yeah,
okay.
thank
So
you.
if you like in between, if you feel or somebody, any residents or the any feel about that they are not able to see it, let me know. So we'll try
Yes.
to modify accordingly.
Okay.
Okay.
Yeah, just go on.
So as I said that we can discuss this role of MRI in following heading. One is the detection of, can you see my arrow also? Is that arrow you are able to see me?
Yeah,
Arrow?
I can see the arrow.
Arrow, okay, that's good. And then the second point is to characterize the lesions. Then third is the extent and staging of the lesion. And then the last one, we'll see how the MRI can help in the post-treatment assessment. Okay. So this is the protocol. Obviously, the protocol can be differing and different institution and what kind of, I mean, the machines you are having, whether the Siemens or Philips or any machines are there, or your upon sometime it depend upon also that what your surgeons, the onco surgeons or the orthopedic surgeons want. So it may be differing, but most of the places you need a T2 weighted images in two planes. T1 is very important for tumors. You can take in coronal or axial, at least in two planes. So many people take in coronal plane, some people take in axial plane, and then some people use it post imaging. So there is always debate about it whether you need contrast imaging for the bone tumor or not. Some the European the institution they think that the contrast is not required. Some people say that still the contrast is useful for them. So it's up to you and it is your compatibility whether you want to use the contrast or not. And then we will discuss the advanced sequences like perfusion, like dynamic contrast, and the DWI. We will see that the role also. So you can see those situations also that whether these advanced sequences are needed or not needed. So let's come first with the detection, how the MRI can help in the detection. So this patient was the 5-year male and presented with the swelling in the arm. And on radiograph, you can see by the arrow, then you can see there is a soft tissue swelling and the bones looks like normal. So the clinician are probably thinking that probably this patient has a soft tissue mass lesion. And then they send for the MRI. So what we see in MRI, you can see this is a T1 weighted image on the left side and this axial T2 weighted axial images here. You can say that there is a large soft tissue mass surrounding the humerus here, and there is a signal changes in the humerus also, particularly the medullary region. There is a little bit of minimal the thinning of the cortex also. On T1 weighted images also, you can see it's little bit of hypointense signal in the medullary cavity. So by doing just conventional T1 and T2 weighted imaging, you say that this lesion is arising from the diaphysis of the humerus with the large soft tissue component. So the lesion in the bone is little, but the soft tissue component is asymmetrical, is more than what we usually expect. So it's usually these patients are like the Ewing sarcoma. These patients present like this one sometime in this location because of the considering the age as well as the location as well as the component soft tissue component large soft tissue component. You can say that this mass is and so by MRI you can characterize that this lesion is not only confined to the bone the soft tissue but is actually arising from the bone but the large soft tissue component. So now you by MRI, now you say that the lesion is a bone tumor with a large extracellular large soft tissue component. Here you see this patient actually presented with the soft tissue swelling in the popliteal fossa. And this patient actually sent to us that probably they are the clinicians were thinking of soft tissue mass lesion. And then when we did the MRI, you can see this actually apart the osteoarthritic changes, the fusion, and there is a large cystic lesion in the popliteal fossa. So actually, this is not a soft tissue mass lesion; it's actually a large Baker cyst. So, and you can see on axial images also that is communicating with the joint here. So, so this is a very typical imaging feature of the Baker cyst, and these patients can present with the as a large soft tissue mass lesion, sometimes quite hard to feel about it, and so sometimes the clinician think that probably they are dealing with the soft tissue mass lesion. So MRI can detect that this is a not a mass lesion, it is just a Baker cyst. So if you tell the clinician as well as the patient will be more happier that whatever the pathology they're suspecting, it's not like that, but actually it is a large cystic lesion, large Baker coming from the joint. So that is the important point the MRI can tell. Let's see the characterize. So apart from the detection, how the MRI can characterize the any mass lesion, whether it's in the bone or in the soft tissue lesion. So let's see this case. This patient was a young male, and on radiograph you can see there's a large the mass lesion, and it looks like more opaque lesion here, and looks like arising from the femur, neck region as well as in the upper diaphysis, and because of the overlapping also, and looks like that probably we are dealing with the osteosarcoma. Like men, you see the normal radiograph also that on radiograph when this is more of opacity, and it's look like a lobulated lesion, and looks like so osteosarcoma. So the clinician were thinking osteosarcoma, and then they sent for the MRI, and then we can see on MRI that this lesion is a quite lobulated lesion arising from the femur, and this looks like more cauliflower-like mass. So you see, it's a cauliflower-like lobulated mass lesion, and this lesion has a very typical hyper-intense cartilage cap, which is some places is thin, in some places is just little thicker. So now on radiograph it looks like sarcoma, but on MRI, because it's not a large mass, now on MRI you can say that this region is a osteochondroma, which was because of the overlapping of the bone and the large osteochondroma. It was looking like a kind of osteosarcoma or maybe kind of indeterminate lesion. But by doing MRI, you can definitely say that this is a osteochondroma lesion arising from the femur, and it has the cap. So cap is also very important identification of cap. How thin and thick of the cap is there. You can make it that this lesion is a benign osteochondroma versus malignant osteochondroma. Some people say the more than 10 or 10 millimeter or more than 15 millimeter size a lesion can be of the malignant condition. But you have to look for as a overall features also. So always look for the cartilage cap and any kind of changes, the erosion, the destruction, or marrow edema, just to say that this is a benign lesion versus malignant lesion. So on MRI, this patient, we could diagnose this lesion is a benign lesion, benign osteochondral lesion. Here, this case was a known case of osteochondroma, and again presented with the growing soft tissue swelling in the hip region. And you can see here there is a large osteochondroma, the sessile osteochondroma arising from the left side of the ilium, and there is a large soft tissue component here. So this large soft tissue component is a malignant transformation. So this is CT, and you can say this is MRI. So on CT scan also large soft tissue component. But what is the MRI is doing? By MRI, you can say that the MRI that the lesion is a hyper the hyper or you can say there is more signal intensity, hyper signal intensity within this one, and this lesion they are usually a feature of suggesting a feature of the malignant transformation. So it's more of a chondroid lesion. So again we will see the later slide also the chondroid specific lesion on MRI. This shows hyperintensity, very lobulated, and more kind they can show popcorn kind of the morphology, and very typical ring kind of the enhancement and post contrast images. So this is a very typical the imaging features of the controlled lesion. And obviously there was a other small the osteochondroma. So this was a case of a multiple osteochondroma lesion, and in one of the osteochondroma it shows the malignant transformation. So on MRI we could characterize the lesion, whether this lesion is a benign lesion like in previous case, or this lesion is a malignant lesion if we see this kind of features on MRI. So MRI is again very useful in characterize the lesion. See another case here. This patient presented the pain in the shoulder region here. On shoulder, in the radiograph, what you see, very ill-defined lytic lesion in the acromion here, or probably we don't know about whether the joint is involved or not, but you can see the lesion and acromion. So there can be a very differential diagnosis. On radiograph, if you put on the radiograph, there can be a lot of differential diagnosis. If you consider the age, which can be like cyst or maybe GCT, considering this, or maybe any malignant condition or malignant lesion here. So, I mean, there can be various different differential diagnosis. We are not going into detail of the differential diagnosis, but considering on radiograph, there can be various differential diagnosis like tumors or tumor-like conditions. They can be there. But if you do the MRI here, you can see on MRI the T2 weighted images as in the post contrast image here. Again, we can see there is a the hyperintense signal, lobulated mass lesion, and with soft tissue extension also here. On poster contrast image again, so is a kind of the ring kind of popcorn kind of the enhancement here. So by on MRI, we could tell that this is not a just a simple cyst or a GCT or maybe any other kind of the lymphoma, because it can show the very typical imaging MR feature and the enhancement pattern. Then you can make a diagnosis as it's a chondro lesion. So most likely is a chondrosarcoma. So and that way, so not all cases we can make a diagnosis. Some, but in some cases, if this shows the typical imaging features on MRI, you can tell that this is a chondro lesion and likely of chondrosarcoma. See this case, this patient presented with the soft tissue swelling in the hip region. Last soft tissue swelling in the hip region, you can say there is soft tissue swelling on radiograph, and we could not see any lesion in the bone. Then again, clinicians were interested whether this lesion in the soft tissue or this maybe this soft tissue mass lesion or mass like lesion there, or maybe bone tumor here. So we did the MRI here. But MRI, what you can see on MRI, you can see the MRI, there is a large lobulated again mass lesion in the hip, the gluteal region, and this lesion is extending into the pelvis here through the sciatic foramen here. And the characteristic imaging features that it shows the fatty signal intensity. Like here you can see this is a fat, and this signal intensity is the same. So the signal intensity of this mass lesion is equal to the fat, subcutaneous fat here. So and it is suppressed on fat suppressed images on the right side of the skin, and it's nearly completely suppressed except there is a little bit of the stranding or maybe septate. So now on imaging you can say this is a large lipoma or fat containing lesion, which is not only limited to the hip region or the gluteal region, this also extending the pelvis through the sciatic foramen. So the clinician will be happy, but because you already characterize the lesion, you told the actually the extent where is extending this one. So surgeon's point of view will be much beneficial for them, and they will operate this patient according to your information you have given to the your surgeon. So that these things are very useful, and MRI can tell you not only characterize, but it also tells you the lesion where actually is lying and where is extending. Here again there is a case. Again, this patient presented the large swelling in the thigh, the thigh region here. You see, again there is a large soft tissue mass lesion, which again contain the fat, contain signal intensity here, same signal intensity of like the fat. But apart from that, you can see some nodular lesion in the fat. Like in the previous case, there was really the similar, the homogeneous lesion. Here, this fat containing lesion is not homogeneous and it's showing the hypointensity nodule in between also. And fat suppressed images, you can see that there can be some this is post contrast images, but it's fat suppressed. So you can the fat is suppressed, but there is a enhancement of the nodular region here. So it's not just a simple lipoma, it's a malignant condition because of the enhancement and this location where it's lying so deep, its lesion is located very deep into thigh and it's a in showing the nodular enhancement. So it's a there's a liposarcoma and it turned out to be liposarcoma. Obviously, you can tell the what are the feature any the nerve is involved, how is the neurovascular bundle is there. Again here the neurovascular bundle is not involved. It slightly compressed little bit of the encasement on the posterior side. So these points are very important. So if you can characterize the lesion as well as you can tell the surgeons about the neurovascular component, whether it is encased or not encased by the mass lesion. So after the 2 point, we come to the stage. As I said, the extent and staging. The staging for the bone tumors is very important. So for surgeon's point of view, management point of view is very important. We can diagnose the patient by MRI also, but we can stage the lesions, particularly malignant condition, whether it's been involving the bone or in the soft tissue. So accurate, as I said, the accurate preoperative staging is very important. The clinician, it helps the clinician to choose appropriate therapy. They want for what kind of therapy they want to go for. Now, whether this lesion is extending into the bone or the soft tissue, or how bigger the size is there, so they will treat according to that. So, purpose of staging is to define local staging, extent, distal extent, and determine the surgical margin. The surgical, they want to know about the surgical margin, and then the status of the neurovascular bundle. So, MRI remain the modality of choice for the local staging. Local staging is always, or the orthopedic surgeons or oncosurgeon always prefer MRI. Obviously, if you want to do the complete the staging, many people prefer the PET CT, or even some also prefer the whole body MRI also. So again, this always remain the person choice, ortho surgeon choice, orthopedic surgeon choice. They want to go for the whole body MRI versus the whole body PET scan. So, what can be done for to see the extent and staging of the lesion? We should mention the location, where is located. It is subcutaneous, intramuscular, or in the bone. What are the compartment involved? Muscular compartment or subcutaneous? Size, always mention the size of the mass lesion, and all three extend the superior to inferior and anterior, posterior, and lateral. All three component size, the measurement should be taken and given to the surgeons. As I said, the relationship is very important for surgeons when they want to operate these patients. If you see the lymph node involvement adjacent to this one, or if the lesion in the thigh, always look the lymph node enlargement in the inguinal region. For pulmonary and other metastasis, many the institution after the MRI of the local stage, people usually prefer the CT scan of the chest to see the any kind of the pulmonary involvement. Now people think that we want to see the any other areas also. So people prefer or the PET scan. So it's always, as I said previously, some people prefer the PET CT. Some people just go for the CT scan of chest just to see the any involvement of the pulmonary metastasis in the lung. Okay. So what is the staging? Obviously, there can be various staging also. So this was the kind of previous staging was previously used, and this was very simple staging because they just wanted to know that the tumor is intra-compartment or tumor is extra-compartment. So like here the T1 or T2 images and the metastasis, like whether the metastasis has been there or the grading of the tumor itself. So it was very simple the staging which was previously used. Later on the like this way here. So suppose this lesion. So this lesion is a intra compartment. So the lesion is is involving the bone, but is not extending to the soft tissue component. So it will be T1. When this lesion is not only limited to the bone, another patient, but this lesion is extending into soft tissue and adjacent area. So this lesion become T2 immediately. Okay. So these are very simple, the classification system. Later on, there was a the more more changes were there in the classification, because they want to know that how much is the size of the lesion, where actually is going, and the lymph node and metastasis are also they need to know about it, as well as the grading of the tumor. So again here the role of radiologist to know about the kind of tumor, whether it is T1 or T2 or lymph node lesion or metastasis. Grading is more of pathological. Okay. So here the classification here, the tumor size. The tumor size depend. Like if the T1 is a tumor 8 centimeter or less. If T2 is more than 8 centimeter in the greater dimension, whether it's a the transverse or superior to inferior. So this was based on that. The lymph node also, whether the lymph nodes are involved N0 or all involved, and it's like the metastasis also. So here, actually what happens, they included the size of the lesion also, apart from the intra and extra compartment component, and as well as the metastasis also. These are included. So it's a more detailed the classification system, which we call the AG and AGCC classification. So many people use this classification. It's because it's more detailed and tell you about the all the imaging features as well as the staging. So this case is actually here. You can say this looks like the lesion is more of parastral here, not involving the bone here. Another patient, you can see the mass lesion, not only involving the bone, but there is the soft tissue component here. So in this recent classification, or we can see the updated classification, you should tell actual length of the lesion from where to where it is rising. So if it's up to 8 centimeter, or it's more than 8 centimeter. Here on this side, you can see the lesion, but there is a skip metastasis is also there. So then you can think that the skip metastasis comes into the here. So you can see the discontinuous tumor. So it become a T3 in the primary. So when the lesion is discontinuous, it become a T3 lesion. Here, see the lesion. Here, this patient presented with the large soft tissue mass lesion here in the gluteal region. And you can see there is a large soft tissue component here. But if you do the MRI, you can see the whole detail of this component. So this you can see there is a large soft tissue mass in the gluteal region, and then is also extended into the large component also in the pelvis region through the greater sciatic notch. And this lesion not homogeneous, it's showing the heterogeneous, as well as this is showing lot of necrosis here also on post contrast images also. And you can tell the whole extent where actually is going, how much is the size of the lesion. You can measure the size of the lesion, how much is the size of lesion is going into the in the pelvis also. And then what is happening to the bone, what is happening to the neurovascular bundle, the sciatic notch, or as well as, or what is happening to the other neurovascular bundle in the side, this like the artery and the nerve. So these all extent you can tell, because these lesions are can spread into the intramuscular location. They can go into the subcutaneous location. They can go to in the pelvis. They can destroy the other side of the bone also. So these imaging features, the clinician are thinking of doing the surgery, or then they need to know actual extent of the lesion, how many structures are involved, where is extent involved, what is the component, or what are the status of the neurovascular bundle. So these all kind of information surgeons want to know about it. And as a radiologist, by doing MRI, you can tell the actual extent, and you can do the staging by following the any classification system, whatever you can follow. See another case here is case of osteosarcoma. You can see there is a very typical periosteal reaction, the sclerosis of the bone, the soft tissue component here. So again, it's very typical of the osteosarcoma. aggressive lesion here. On MRI, you can see there is the bone lesion, the soft tissue component. On axial images, T1 weighted images, the bone lesion, the bone destruction, cortical thinning, large soft tissue component, and the neurovascular bundle is partially encased. Here you can see the neurovascular bundle is partially encased. So this information is very useful for the clinician's point of view. And obviously, this patient, when we did the CT scan of the chest, we could find out there's multiple the lesions, oval shaped lesion, rounded oval lesion within the lungs. So pulmonary metastasis is there. So this become now a stage 4 lesion because it's already metastasized. So by local staging and when by doing this chest CT scan, you can tell the surgeons that this patient is already metastasized, and then the treatment or the management will depend upon the whole staging. Next comes, we have discussed the 3 point. Now the last point of our topic here is the post-treatment response. So as I said that the role of radiologist not only to detect the or diagnose the lesion or the staging of the lesion, you can also help the clinician what is happening in the post-treatment assessment. You can do the post-treatment assessment because many of the malignant conditions or malignant tumor, they are responsive for the chemotherapy, and the surgeons and oncophysician, when they give the chemotherapy, they want to know about it whether the chemotherapy is effective or not. So they want to know about it, and in those situations, the radiologist can help. Other point here also to distinguish post-treatment fibrosis from residual recurrent lesion. Then another condition where tissue mass lesions. Usually, the patient after the post-operative after the surgery, sometimes they feel some lesion and this post-operative scar. Then when it comes to the surgeons, operative surgeon, surgeons want to know it is just the fibrosis from the previous surgery or it's a recurrent of mass lesion at this location. So in both the condition, the radiologist has a role, and we will see how the radiologist can tell. So how to see the treatment response when the malignant condition is there, the bone tumor is there, and clinician are giving the chemotherapy, then how do you know about that the chemotherapy is effective or not? So that is the one important to know about it, the percentage of tumor of necrosis. If the tumor show the necrosis, then it shows that the patient is having the treatment response or this treatment, whatever treatment is given to the patient, it is patient is responding to that. The size of signal intensity on conventional MRI, sometime, obviously, many time it's useful, but sometime not very reliable when the lesion is small and it is only the bone is involved. Then on this situation, you can do advanced MR sequences like dynamic contrast enhanced MRI or diffusion contrast MRI. They are useful. We'll see in the next slide. Another new technique, as I said, the diffusion weighted imaging also, and many studies have shown that the ADC correlate very well with the treatment response. So what happens in the diffusion weighted images? Like when the patient have a low ADC, then if the changes during the treatment, that means the patient is responding. In spectroscopy also, when there is a choline is there and this choline level changes, then again you can see that the patient is getting benefited. Obviously, nowadays the MR spectroscopy is not routinely done. Most people are either doing the diffusion or DWI images or dynamic contrast imaging to see what is happening into the tumor. So this is a kind of conventional MRI. If you see this conventional MRI, then obviously you can see that like this is the kind of weak sarcoma patient here. Now on follow-up cases, you can say that most of the soft tissue component has resolved. Only some of the hyperintense signal are there in the bone. Most of the soft tissue component has resolved. So this is a conventional MRI. Now you know about it by visualizing this one that this patient is always having this treatment response. So this is kind of conventional MRI. And this by visualization also, just visual way also you can tell this the patient is responding very well with the chemotherapy. But in not all cases, this visualization is very good. Like see, and we'll show some of those cases later on. So what is the role of advanced MRI? Like we as I said, the diffusion weighted imaging show the cellularity of the soft tissue component or in the malignant bone tumor. So more cellular lesion is there, more hyper the diffusion restriction will be there and will be low ADC. In cases of perfusion or dynamic contrast enhanced imaging, we'll see how much the vascularization of the tumor is there or the soft tissue tumor, and then we see that how the vascularity, not only the tumor itself, but we want to see the dynamicity of the vascularity. That is very important. Spectroscopy measures the metabolism or the choline level. As I said, usually people are not doing very routinely, but sometimes you can use it if you are doing some the project or some thesis, then you can do it. So what is the how the diffusion helps and what is the diffusion weighted images? So we all know that diffusion measures the Brownian motions of the water at microscopic level, and the diffusion has been used in many conditions. The brain, the abdomen, lot of other the system, and people are using. Like in the stroke patients, people are using since many years. So diffusion is not new, but people are using less and less in the musculoskeletal system. So it's important to learn that the diffusion can be used in musculoskeletal system. So as I said that the analysis of the diffusion restriction and the ADC map, you can make it and then you can assess those. Low ADC means that cellular tissue is high. So when those the condition where the tumor has a more cellular component, then the ADC will be low, and in those situations the diffusion restriction will be okay. So several studies have shown that ADC correlate very well with the treatment response. So when the tumor necrosis occurs, the ADC value become more. Normally more cellular component, low ADC. So there is a always inverse relation between the diffusion restriction versus the ADC map. Okay. In situation where the diffusion restriction is there, ADC will be low. Diffusion restriction will not be there, then the ADC will be higher. So anything which happens in the ADC changes after giving the treatment, you mean then you can say that the patient is responding very well with the chemotherapy. There are other indications also of the diffusion weighted imaging, and this is the one indication where we want to know the more cellular component, so we can do biopsy from this region. So this is one patient here. You can see this is a large soft tissue component, large malignant mass lesion from the bone, and the cellularity is more in this anterior location in comparison to the posterior location. So if you do this biopsy from this location posteriorly, the yield or the chances of getting the tumor will be less in comparison to if you do the biopsy from the anterior aspect. So always important if you or sometime the biopsy does not have any the result, and the surgeons want to know you or they want some help from the radiologist, that can you pinpoint the region the more yield or more cellular lesion, and then we can do the biopsy or radiologist can do the biopsy from this particular region. Okay. As I said that diffusion can be used in post-treatment cases. Here you can see these cases of the treated cases of the Ewing sarcoma. The T2 weighted images showing the hyperintensity, little bit enhancement was there here. For diffusion on ADC value, the ADC value is higher. So as I said, the higher ADC value means the cellularity is low. That means this patient is responded very well. So diffusion, by doing the diffusion, you can tell that the viable tissue is will be much less if the ADC value is much higher. So that's the important one, the thing want to communicate to you, that the diffusion is very useful in some situation, which can tell you that the viable tissue or viable malignant mass is there in that particular location or not. Coming to the perfusion or dynamic contrast enhanced imaging, as I said that by dynamic contrast enhanced imaging, you can see that insight within the vascularity of the tumor. And how you do it? Normally, we inject the contrast and the GRE sequence, which is quite fast, and see how the contrast goes from the artery to the capillary, and then how it was out, and that we can make it by the time intensity signal, intensity curve, which we call TIC, or time intensity curve, and we can do some semi-quantitative measurement also to know about it, what is happening within this tumor itself. So if you do the if you do the dynamic contrast imaging, and if you make this time intensity curve, these kind of curves you can make it, and this is the already given in the literature. So normally, like, this is the signal intensity and this is the time. So we can plot this time signal intensity curve here. So that means there is a no enhancement in the curve. So this is a flattened. This curve, type 2 curve, shows that is a slowly run, the gradual. So the enhancement in the tumor is very, very gradual. Okay, here like this. In type 3 curve, you can see there is a sudden, or maybe there is a rapid wasting here. But after that, there is a plateau. After that, it's not coming down. So there is a rapid washing, and then later on the plateau phase. In type 4 curve, it goes up and this goes wash down also. There is a wash out phase also. You can see the wash out phase. So this, most of the tumor in the malignant condition, they show this kind of features here. The less aggressive feature, the conditions or tumor, they show this kind of the curve. And then some of the cases, like some of the cases, they will show um, rapid uptake of the contrast, and then again there is slowly its uptake is there. So just to remember that necrosis will show, if any tumor, necrosis will show this kind of curve. Less aggressive or benign tumor show this kind of curve, and more aggressive or malignant conditions show this kind of curve. So how to assess the chemotherapy, the monitoring? Again, as I said, when this poor responder, if the response is poor, then the change in the time signal intensity will be minimal or may decrease. But in cases of good response, you will see the slope value changes. And obviously, we have to do the semi-quantitative measurement also. So see this case. Here, this was again Ewing sarcoma on post-chemotherapy. This T2-weighted image, you can see there is a soft tissue mass arising from the bone and large soft tissue component here. This is T1-weighted images. So actually, on clinically, this patient was not behaving. I mean, the patient was not responding well according to clinician. So they want to help. They want to take the help from the radiologist to know about it, whether this tumor is responding to chemotherapy or not. So then we did the dynamic contrast enhanced MRI. So see this one, the MRI, and we put it multiple ROI curve. Okay, so multiple we can make it. You just push the ROI here, any places, and then you can see the time intensity curve here. So this red one, the red curve, the signal is red curve is because of the artery. See here, the artery, the ROI is put it in the artery just to compare what is happening to the other curve, and then we put it the ROI in the mass lesion as well as the non-enhancing area. So 2 is one here, and this 3 here is it going down here. So this curve, what this curve shows, that this is the artery, and this is the even the malignant the tumor is showing this curve, and this third curve is showing non-enhancement. So that means this is necrosis is there. So by DC-MRI, we can tell the surgeon that this patient is having the necrosis, and the necrosis means that if the necrosis is developed within the soft tissue mass, malignant condition, that means the patient is responding. As I said previously, is a good marker. The necrosis, development of good necrosis is a good marker, and you can tell by the contrast enhanced imaging as well as DC-MRI that the patient is responding well in the chemotherapy. If you tell this finding, the clinician will be happy, because in these patients sometimes the size of the lesion does not decrease. Like in conventional, I showed you the conventional way of looking for. In this situation, the exact mass is not significantly decreased. But if you show the necrosis within the soft tissue, then you can tell that this patient is improving on chemotherapy. Again, this case of the sarcoma, soft tissue sarcoma, here again T1 and T2 weighted imaging, very typical imaging feature of the sarcoma, again was on treatment, again they want to know about it, whether this patient is responding or not. And we did the diffusion in this diffusion. So see here, this is diffusion restriction here, and the diffusion restriction show the low ADC. This is ADC map, and this is the diffusion. Here the ADC is low, that means the cellularity is much higher. But in this location, you can see the ADC is higher. That means there is necrosis is there. So as I said previously, if you demonstrate the necrosis within the soft tissue or malignant conditions of the bone, you can tell the surgeons that the patient is responding. So again, necrosis is the marker. Necrosis is the marker of telling that the patient is improving on chemotherapy or whatever kind of the treatment is given. We did the dynamic perfusion also in this patient. Again, the same kind of the things are we can see there's a lot of necrosis here, and this area are not showing the necrosis. So showing the necrosis within the soft tissue by dynamic perfusion or diffusion, you can tell the surgeons and you can help the surgeons or the onco or your clinician about the patient that the patient is improving. So this was the curve in this previous case. Again, you can see there is a lot of necrosis, and this curve is the arterial curve, and there was a lot of curve, the lot of necrosis. We put it to the ROI in the necrosis. Coming to the last one, the important one again, we can differentiate the lesion, whether it's a lesion, the recurrent lesion is there in the post-operative site, or the just a fibrosis also. So again, the DCMRI as well as a diffusion, DWI are useful to detect these lesions. The DCMRI is useful as well as diffusion. I will show one of the case here. So again, the same case here, you can see again the Ewing sarcoma case, post chemotherapy, this case here on see the DCMRA here. You can see they put it the ROI here. This is the arterial curve and this is the curve here. So it's not showing like the enhancement pattern, it's just showing more of kind of flattened the kind of the curve. That means that there is a viability of the cells or viable tissue is the chance of viable tissue within this lesion area is much less. So definitely you can tell your surgeon that the chances of viable tissue is less and the patient is improved very well in this situation. So coming to the summary, as we've seen some of the in last 30 minutes or so, that the MRI is a modality of choice. So what is the how the MRI can help? That it can stage the lesion, it can characterize the lesion. We have seen, and it can characterize the soft tissue. Is it like it's a lipid containing lesion, the fat containing lesion versus the other lesions? We can characterize the lesion itself. So obviously, I have not shown to a lot of other soft tissue tumor or the benign looking like lesions in the bone or MRI because of the limited time. We want to show you that the MRI is quite useful, but we should remember how the MRI can help. So number one, we discuss the detection. The MRI is useful to detect the lesion, whether the lesion is in the soft tissue or the bone or is a non-tumorous condition. The second is to characterize the lesion. If there is a lesion, whether this lesion is a benign lesion or a malignant lesion, if it is a malignant lesion, whether it is a chondroid lesion or is a lipid lesion, fat lesion, or maybe fibromatosis. So second important component that we want to know about the lesion. We want to make the actual diagnosis in this lesion. So MRI can characterize those lesions because as I said, we have seen some cases where the MRI are very useful, like chondroid lesion kind of thing, we can easily identify and easily determine by the MRI. And the third point is the staging. Staging is also very important for the surgeon's point of view, and the radiologist can give you all the answer whichever needed by from the radiologist, from the orthopedic surgeon. And the third and the last point, we can help, as a radiologist, we can help the clinician to make diagnosis or make in cases and treatment response, whether we can tell that this whatever the treatment you are giving, particularly the chemotherapy, on that chemotherapy patient is responding or not. And obviously remember this one, that is the complementary all advanced technique like diffusion weighted imaging or dynamic contrast enhanced imaging or spectroscopy, they are added. You cannot replace these sequences with the normal T1 and T2 weighted images. And always, in particular in the bone tumor, always remember, again I am stressing about this one because I always tell our trainee and the resident who are working in the hospital not to always look for the radiograph. If it's not available, please get it done for the any malignant condition. So malignant bone tumor is there, always look for the radiograph. And if there is soft tissue tumor, always look for the ultrasound, because ultrasound is many condition. Ultrasound is very useful, and many time it can make a diagnosis. But like a lipoma, many cases lipoma the MRI is not needed, and the other conditions, many conditions, the ultrasound is quite diagnostic on those situations. So always look for the ultrasound imaging features. So always kind of thing, if you understand that how the ultrasound, how the MRI can help, how the radiographer can help in this situation, always always communicate with your clinician. Always want to know about what the clinician want from the radiologist. Multimodality, like always we see the MDT, where we need the help of the pathologist, need the help of the orthopedic surgeons, need the help of the radiologist. So all a kind of we should work as a team, including the oncosurgeons, oncophysicians, radiologists, and pathologists. You should come under one and discuss every time whenever there is a malignant mass lesion in the bone or in the soft tissue. So that's the thing I wanted to tell you, that the MRI is very useful in the not only the malignant condition but the benign condition too, in this whether it involved the bones or the soft tissue. And we have seen how the MRI can help, and we have seen last half an hour or so that it's very useful, and we should know about it where MRI can be useful. That's all from me, and this is thank you from my side. Over to you, Dr. Rosy, and if you have any question, I will happy to answer.
Okay, thank you so much, Prof. Mahesh, for the wonderful presentations, very clear and detailed, yeah, explanation about the principle of of using MRI in bone and soft tissue tumor. And right now, I will give an opportunity for the participant to give questions by
Yes.
raising your hand from the Zoom meeting, and maybe if there is some questions for participant in YouTube, so you can see or put your question in your chat box. Okay, please, anyone to ask something from the expert here? Okay, please raise your hand. Who is raised? Oh, okay. There are three. I'll see who is the first. Okay, I will let Dr. Hammam first to give a question. There is a four participant who raised a hand. Okay, please,
Okay.
Dr. Hammam.
Sure.
Thank you, Prof. Thank you, Prof. Mahesh and Prof. Rosy. My name is Dr. Hamam from Radiologi Surabaya. I want to ask a question for the part is the first is MRI is useful for the assessment of the treatment response, but which is the strongest predictor for the good pathological response? Is it the size on the changes in enhancement pattern, on the changes in adhesive value, and how much the changes in adhesive value for the good pathological response? And this is the second, but is my curiosity for which is what annotation should we use for guiding the interventionist for the right biopsy. Thank you, Prof.
Okay, so you wanted to ask that the question related with the treatment response. So as I said, the treatment response can be possible with the both sequence, apart from the size and everything. That is the most like very visual. Many patients, like I say, I shown one, like if the lesion, the size and the morphology changes, then obviously you know that the patient is improving. But in actually say like the size does not go down very very fast, and they go very slowly. So even now the because new adjuvant chemotherapy are coming up, so actually the surgeons or the onco physician, they want to know about it whatever the treatment is given in early phase, because these medicines are very costly. So they want to know about it, that this patient the patient is improving or not. So in those situations we can do the advanced technique, but obviously we the size and everything matters also, but it happens late. But so early stage, we need to do this advanced technique to know about it, because we want to know about the necrosis. And if you can tell the necrosis, then you can say that probably patient is improving. The second, I think, the question was related with the intervention radiologist, where to look for the biopsy. So again, as I said, that we can do the diffusion weighted imaging to see the more the lesion, I mean the kind of the density lesion there. So more where the low ADC will be there, you can do biopsy from that side.
Okay. Is
Thank you,
that
Prof.
satisfy you, Dr. Hamam? I think it's quite complete, yeah, answer. Thank you, Professor Mahesh. And I will please the another participants, Dr. Erin Pradita, to give your questions to Prof. Mahesh. Please.
Sure,
Okay,
sure.
Prof. Actually, my question is similar to the previous one. If the mass remain large but the necrotic component is expanding, does that mean there's a response to the therapy? Because during baseline imaging, we can also detect necrotic component in malignant masses. And is it still necessary to evaluate the necrotic components curve to confirm that it's truly necrotic or not? Thank you, Prof.
Yes, yes, that's a nice question actually. So this is what happens normally, like in the contrast. If you see the normal contrast, what we do, we normally we don't do the dynamic contrast. So if you just show the necrosis by just simple contrast, then you can maybe either underestimating that the necrosis. But if you show that the by dynamic way, the best way is the dynamic way. But you can put it like, if you do dynamic, then the time intensity curve comes like nothing much the work is required. So you can just plot it, the time intensity curve. So time intensity curve, but if you can see visualize by visual eyes also, that's also good enough. But it's better if you can you can plot the time intensity curve. That is much better.
Okay.
Okay, thank you, Prof.
Okay, thank you, Dr. Erin and Prof. Mahesh. And another questions come from Dr. Akitsa Malini. Okay,
Okay.
please, Dr. Akitsa.
Okay, thank you, Prof. Rosy. Good afternoon, Prof. Prakash and Marisa. I would like to ask you about um, osteochondroma. If there is malignant degeneration, we have to measure the thickness of the cartilage cap. And based on your experience, what is the best sequence to evaluate the cartilage cap? Thank you, Professor.
Yes. Yes, yes. Thank you, thank you. Again, this is this is very important point to the resident point of view. So no, we know that the cap is best visualized on PD fat set or T2 fat set images, because otherwise in T1 either we will be underestimating. So best sequence, if you can see, is the PD fat set or T2 fat set imaging, where the cartilage cap is hyper intense. It will be bright on see. So you can measure that way. So that is the best you can measure. So T2, if you are doing T2 fat set, that's okay. Some people do PD fat set also. That is also because we want to know about the cartilage caps, and cartilage caps comes well in case in the T2 or PD fat set images. So you can measure from there.
Thank you very much, Professor.
Thank you.
Okay, thank
Okay.
you, Dr. Akitsa and Prof. Mahesh for the clear explanation. And also, this is, I see there's only one remain
Dr.
for the
Hesti, I
questions.
think
Yeah,
Dr. Hesti is also there.
Dr.
This,
Hesti. Yeah, Dr. Hesti.
Yes,
Yeah.
yes,
yes, yes, please.
Professor.
Yeah,
Thank
thank you.
you, Prof. Rosy and Prof. Mahesh. Such a wonderful presentation. If you permit it, I want to ask you three questions. The
Sure,
first
sure.
one, thank you.
Hmm.
The first one, you said before that the decrease of choline levels and increase of ADC value, it's a significant positive indicator of a tumor response for treatment. And I want to ask you, is there any ratio indicates a significant positive response when we compare to the previous MRI? And the second question, how we can differentiate recurrence from post-treatment changes, such as radiotherapy or chemotherapy changes of the lesion and post-procedure infection. The third question, is there any place for sequence proton density for evaluation bone tumor? If so, what cases are involved and how about the role? Thank you, Professor.
Okay, so I think first thing you wanted to ask about the tumor necrosis. The tumor, can you repeat this question, the first one? Tumor necrosis you want to ask?
All right. The
We'll
first
go one by
question.
one. We'll go one by one, please. Okay. So I just
Okay,
forget
okay.
it.
Yeah,
We
you
can do
many
one by one.
questions.
Yes, please,
Okay,
please,
one
one
by
by one.
one, by
Okay.
one, by one.
Yeah, okay. Sorry, Prof. The first one, how much decrease of choline levels and increase of ADC value to show significant positive indicator of a tumor response for treatment? If so, there is any ratio to indicate a significant positive response when we compare to the previous MRI? Thank you, Prof.
Yes, yes. That's a good, interesting question. So obviously, like people have done it. The ideal thing is like we should do first the preoperative or MRI spectroscopy or dynamic contrast imaging, and you know that how much, what kind of curve is there. Semi-quantitative methods are also available. I did not show you the semi-quantitative method, like how much the TTP, how much the wash in rate, how much the wash out rate. So I was not going to detail, but the best one, if you know the best one, that you should do the same sequence preoperatively and same sequence after chemotherapy. The issue comes like whenever the patient usually come with the diagnosis and the MRI from outside, and then the our surgeons or our physician, they come to us later and that this patient was diagnosed outside from the university, and this patient we thinking this patient is not responding to our chemotherapy. So in those situations we are not aware how much was the what kind of the curve was there, because we they didn't do it. So ideally, if you want to compare, then at least people say that up to 40 to 60% the signal changes in the signal intensity curve should be there. But any kind of the signal alteration in the curve or the choline level will show that it's a necrosis. Suppose everything was the choline level was kind of any level was there, and it's come down and it show the necrosis. That means patient is responding. But ideal thing, like preoperative, you should do the both the MR with the advanced technique preoperatively in your hospital, and you should know how much the semi-quantitative measurement at that preoperative level and after the chemotherapy response. Then you can make a diagnosis. But any more than 20% or more than 30% cases of the decrease of the level, or you just to show the any necrosis. So people have said that the means that the patient is responding. How much it will respond? Because partial response is a response for the clinicians. They, because ultimately patient they want to know about it. The patient is improving on chemotherapy, then the patient may undergo the surgery also. So the if you show the necrosis and if you know the exact value, then you should have a previous the same the MRI in preoperative or pre chemotherapy response at the time. So we have to do, and then you can see that how much the changes are there. But people say that up to 20% or 30% definitely is a initial marker. Obviously, not all patients will show complete the necrosis. Next, what is your next
The
question?
next questions.
Thank you so much, Professor. I will
Yes,
continue to the second question.
yes, yes.
How we can differentiate recurrence from post-treatment changes such as radiotherapy or chemotherapy and post-procedure infection?
Yes, okay. So that's again very the interesting, the important question. So actually, I just showed you to the curve. So normal, like in cases of the fibrosis, the curve is more of like very slowly increasing. Okay. And in cases of the recurrence, because recurrence, the malignant soft tissue, malignant mass lesion, they have a more hypervascularity. So if you know the architecture of the malignant soft tissue which recur versus the postoperative fibrosis, then you know that postoperative fibrosis, they will show very slowly increasing the time, the curve. And the curve in the recurrence will show more wash in, early wash in, and then it can show the wash out. So that kind of curve is there in the recurrence versus the fibrosis. And same thing like in the infection makes the granulomatous inflammation. So again it will be very slow, very slowly growing. That I showed you the curve. Then I can show you, if you want, I can show you the curve again. uh, you want to see the curve again? I can show you. Can you see my slide?
Yes,
So can you see this
yes, I
curve,
can see
B,
your,
this type 2 curve?
yes,
Yeah, we can
The
see.
type 2 curve. So this is very slowly, okay. So this is kind of type of gradual enhancement. So this can occur in cases of the postoperative fibrosis or granuloma and inflammation. But this kind of curve, if you come see this kind of curve, then it may suggest the postoperative recurrence of the soft tissue. So early wash in and then is wash out. Obviously, obviously there can be some overlap also, because we have some the semi-quantitative measurement also, like how much is that from time to peak, how much is the wash in rate, how much is the wash out rate. So these all semi-quantitative measurements also available. But this is the, I mean, this is the gross way of understanding of what is happening in the time intensity curve. What is the last question?
Your last questions, Dr. Hesti?
thank you, Professor. The last one, is there any place for sequence proton density to evaluation bone tumor?
Yeah, that's why actually, that's the point. Some people say there's the proton density can be useful, like because many times the most important the sequence is the T1 weighted sequences, and we should not miss it. But some people do the PD fat set images also, particularly case when the lesion is associated adjacent to the joint, where we need to see the cartilage or something. So I mean there is not much difference between the PD fat set images or T2 fat set images also. You can do like whatever, but most of the people do the T2 fat set. The T1 is more important, not to miss the T1, but T2 is also important. Sometime we tell our technician do the T2 and they do PD fat set images, but we say okay, if you have done then PD fat set images, will okay for that. So sometimes I mean it's not like that we just will go to T2 weighted images only, and we are not accepting the PD fat set. We can accept the PD fat set images, but the ideal thing is if you go for T1 and T2 weighted images.
Thank you so much for your explanation, Prof.
Okay,
Thank you.
Dr. Hesti.
Welcome.
There's still one questions, Prof. Mahesh, but
Yes.
before I let the last so I will continue with the previous question of from Dr. Hesti. So according to the literature and your experience regarding to the post-operative or post-therapy MR evaluation, what is the best time minimally for the patient who wants to do the evaluation, the MR evaluation as well?
Yeah, mostly people say if you need the fibrosis usually occur after the 3 to 6 months of the time, and the so those situations like normally like when surgeons want to do surgery, so at the time of surgery they remove everything. So they are not worried at the initial phase of time. But whenever it happens, normally because fibrosis develop after 3 months or something. So they usually when the patient comes to the follow up, and they see the some swelling is there. So they want to rule out whether this is just a recurrence or something. So at least people say because some of the changes can be some signal intensity changes can be there up to 3 to 6 months. Edema can be there up to 3 to 6 months. So normally people say up to we have to wait for up to 3 to 6 months and before saying that something is happening or not. But there can be a lot of other causes also, like soft tissue swelling. There can be some seroma formation within the operative side. There can be some hematoma, previous hematoma can be the blood collection can be there. So there can be some causes also. Some can be a local infection at this local site also. So they want to rule out everything, and then they will see that probably this is a recurrence or not. So they want to rule out those things also before making a diagnosis of the fibrosis or the tumor recurrence.
Okay, thank you, Professor Mahesh. So I will let the last question from the residents. Dr. Adiwasis, please. Your questions for Prof. Mahesh.
Thank
Yes,
you,
please.
Professor Rosy. Good afternoon, Professor Mahesh, and very interesting lecture. I have two questions, Professor Mahesh. In
Yes.
the first question, uh, sometimes that as we know that if we find some mass in the extremity, the mass can come from the bone or maybe from the soft tissue. But in the advanced stage, maybe in the large mass and with the indistinct margin, sometimes the soft tissue tumor or soft tissue malignancy and the bone malignancy have a similar feature. There are any advice, Professor, if they meet if I meet or we meet the case the mass is very advanced stage, how we can differentiate it fast about both of them from this how to distinguish about the soft tissue tumor and the bone tumor, Professor. And the second
Good, good.
one,
Yeah.
I would ask about your experience, Prof, about the osteosarcoma. I have some problem with the two osteosarcoma. There are yes, we know that there are many subtypes of the osteosarcoma, but two of them is giant cell rich osteosarcoma, and the second one is the telangiectasis osteosarcoma. Uh, Sometimes I have a problem about because the two of both of them have maybe similarity or similar features in the conventional radiography, or maybe a little bit difference about the pathology anatomy. That can is MRI can help to distinguish both of them, Professor, about the telangiectasis osteosarcoma and the giant cell osteosarcoma. Thank you,
Yes,
Professor.
yes. Thank you, thank you.
Okay.
So I think the last question I'll take the first one. So obviously, as I said, the MRI the role of MRI not to make it different osteosarcoma, the different kind of osteosarcoma. So if we know that the osteosarcoma usually diagnosed on radiograph. Radiograph is very important, and most of the cases is diagnostic. The role of MRI here in the osteosarcoma to make it is a like to more of staging here, because diagnosis is already there. People have already done the biopsy or something. So the role of MRI not to differentiate different kind of osteosarcoma on imaging. The role of MRI is to make a more of staging and this level. So MRI role is not there, whether it's the chondroblastic or is maybe the clear cell or maybe the other kind of the sarcoma. So role is not there. That is not there. Our role is more in for the more of staging and the extent of the lesion. How bigger is the lesion? You can tell the surgeon the neurovascular component, how the neurovascular component is involved or not. Those kind of imaging is more important. Uh, Obviously, before diagnosing apart from the osteosarcoma, there can be other causes, other the tumors where the MRI can helpful. But usually we don't try to use ADA to differentiate various kind of sarcoma, because treatment are not much different between the different kind of osteosarcoma. Maybe a little bit of difference, but surgeons want from us to like more to do the more of staging. The first question is, I think, is day-to-day clinical practice very, very important, I think. And you have asked very, very good question, particularly the resident point of view. And even sometimes we also face the same issue there. When there is a mass lesion is there and there is some involvement of the bone also, and we are not sure about whether the lesion is arising from the bone or the soft tissue. So my experience is like that. Like most of these soft tissue mass lesion when arise from the soft tissue and then causing erosions are involving the bone. So we know that where is the epicenter of the mass, and if it's going to the bone, whether they are causing the erosions or not. So soft tissue lesion, if they involve the bone, they will cause starting the erosions and then later on changing in this one. So erosion and the destruction and the epicenter mass. These are the 3 points which say that probably arising from the soft tissue. The lesion arising from the bone usually either will arise from the medulla or maybe the cortex or the paracortical region. So they usually expand the bone. So they can expand the bone and they can come out from the breach in the cortex. So they come from inside out. And the soft tissue tumor goes from outside to inside. So that way you can differentiate. If you can see the more expansion and then cortical breach and then going into the soft tissue, then you can say that lesion is coming from the bone and this is the soft tissue component. So these are the some pointers. Obviously, some cases which I also noticed there is very small lesion from the bone and large soft tissue component, and we thought probably it's a soft tissue component, but it turned out to be the osteosarcoma, which was a very little bony component and large soft tissue component. So these kind of some cases can come obviously, but these cases are very less. Most of the time, if you considering the all the like epicenter and you know how the lesion is extending to the bone or bony lesion coming into the soft tissue, with the large soft tissue coming from inside out, you most of the cases you know, but I understand that there can be little bit cases where you struggle. So that is the thing which can occur.
Thank you, Professor.
Okay, is that enough, yeah, Dr. Adiwasis? I think you, Professor, already gave the very clear morphologic differences within the soft tissue and bone tumor, and also there is no specific or differences between the subtype of osteosarcoma resulting from the advanced MR, yeah, because very difficult, yeah. But sometimes
Yeah.
I can
Dr.
see
Roji,
for
if you have some experience about it, you can also share.
Yeah. From the GCT, I think this is quite, yeah, we have to compile with the X-ray as well. We cannot just only
Yes.
evaluate from the MR result alone, remember the residents. So we have to do the multi-modality evaluation analysis. Sometimes the X-ray give us a very, very helpful informations to guide us to see the histopathologic diagnosis of the tumor as well. Yeah, so please don't forget to see another modality that they have, yeah, the patients have. So we just compile it and then we can do, make a summary from all the imaging findings. I think this is my adding informations.
Yeah,
And
that's why that one point, that's why I want to stress again that if
yeah,
you don't want to learn anything from this one, just learn that don't ignore the radiograph in malignant bone conditions or any tumors from the bone, and don't ignore the ultrasound in the soft tissue contrast. That's all. If you can learn this one,
yes, correct.
always remember the importance of the radiograph. Always remember.
Yeah, because we have, I think we have in Indonesia and India have a similar pattern of the tumor because usually we have a very large, as extensive tumor already. So sometimes we have difficulty in differentiating whether this is a bone tumor or this is soft tissue tumor, and a lot of kind of histopathologic sometimes it's very difficult to be differentiated between one to another type. Yeah, so I think tumor is have a challenging in diagnosis as well as when for the monitor after the therapy, is still challenging. Yeah, the deeper is more difficult. The deeper we learn about the tumor, I think we will the more difficulties appear. So yeah, so just always keep studying and seeing your experience. I believe that starting for your experience, it will sharpen your skill as well. Yeah. Okay, Prof. Mahesh, I think we already waste your time so long. Thank you so much, and
Thank you.
allow me to give a very, very short summary from this talk that the MRI plays the critical role in diagnosis, the local staging and treatment planning, and also follow-up of the malignant bone as well as the soft tissue tumor. And remember that we can see the features of the morphological changes on MRI using the conventional MR, and then we remember that we can see the contrast enhanced MRI that can identify the most vascularized tumor areas, and then to help to guide the biopsy, the site of the biopsy to avoid the necrotic regions. And also, yeah, I think the MRI is highly sensitive and specific, and also have histological confirmations that especially in aggressive and indeterminate cases. And I think that's all my summary. Thank you so much, Professor Mahesh. And as we come to the close of today's webinar meeting, I would like once again to sincerely thank for Professor Mahesh for your excellent presentation and valuable insights, and your expertise has enriched this session and provided us with important knowledge in to advance in our radiology residence. Thank you so much. And once again, thank you for the participation of all participants. And we look forward to welcoming you again, Professor Mahesh, and all participants from all institutions in our future educational event and webinar. Okay, thank you so much. Have a great day. Yeah, thank you, Professor Mahesh. Oh,
Thank you.
maybe I will come back to the meeting to the MC, please.
Thank you. Thank you. Well, my pleasure.
Thank you, Prof. Mahesh and Prof. Rosy. Such a wonderful session. Actually, we would love to continue learning more from this valuable knowledge. But if we keep going, we might still be here until tomorrow, Prof, and we still not have enough. But before we officially close, we would like to kindly invite all participants to turn on the cameras for a virtual group photo. So please get ready, smile, and look at your screen. We will take the photo in 3, 2, and 1. Okay. Thank you. As we close today's session, let us be inspired by the words of Mahatma Gandhi. Live as if you were to die tomorrow. Learn as if you were to live forever. We look forward to seeing you again at our next scientific event. Wassalamualaikum warahmatullahi wabarakatuh. Thank you, Prof. Mahesh and Prof. Rosy.
Bye-bye. Take care. Bye.